Have you ever wondered why asthma can be so difficult to manage, even though it affects millions of people every year? I'm your host, Dr. J. Rutland, back with my fabulous co-host, Savannah Shiles, for another episode of the Health Exchange podcast. In today's episode, we're going to explore the complexities of asthma, my favorite illness, its severity, its treatments, and the underlying immunology that drives it all. Despite asthma affecting 28 million people in the United States and causing 10 deaths a day, I've found that even among healthcare providers, there's often confusion about the best ways to treat it or respond during an asthma attack. If we can better understand the immune system's role in asthma, we can gain deeper insights into why certain treatments are efficacious. So let's dive in and explore how understanding asthma at the immunological level can transform our approach to managing this chronic condition, even in the person who is sitting right next to me.
I think we need to address the elephant in the room.
Is there an elephant in here? Because I do not see one.
I mean, it's on my feet.
Listen, you guys know I'm a sneakerhead. So I had to
I
make
learned
certain,
this about you, but
yes, I had to make certain that your feet match the energy of mine.
he didn't like my shoes. I won't say the name, but he didn't like my shoes. Here I am. I'm doing it for you since this is this is asthma. This is all you. So for you, here we go.
I didn't like the shoes that were on your feet. At all.
Say it how it is.
I just
Can I say though, these are really comfortable.
I'm glad.
So it might be like my new thing. You've converted me over.
I actually think that every guest we have on, we should buy them a pair of sneakers.
That's not a bad idea.
I think that should be.
Be careful what we're throwing out there.
I mean, I'm just saying.
Like our
listen,
guest over here is like, yes, please.
Right. I mean, if you're on the Health Exchange, we will exchange sneakers.
You're serious about this?
Oh, I'm dead serious.
How many pairs do you have? Quickly.
I don't know. 300?
No, you don't.
Maybe. Yeah, something like that.
Where do they go?
All right, so here's the thing. So we had like a big guest room, right? And we built a shelving system for my sneakers, right? So we used to put them in there.
Okay.
And the guest room, we converted into an office.
Okay.
And so whenever I would do the news, right, which was frequently,
yeah,
the background would be like my sneakers. So I was doing the news one time.
Can you imagine watching the news?
Oh, no, I was doing the news one time. It was in Chicago for the American Lung Association because I'm a national spokesperson for them. So we were doing the news. It was in Chicago, and the anchor kept asking about my sneakers.
Okay.
And I was like, done, not doing this anymore. So at that moment, I was like, I can't do this anymore. I can't have this as my background. So took it away as the background, right? And I just had to build shelving in the closet. And then we did that.
Okay.
And then I put them up there, but I didn't have enough space. So now I have them like in the upstairs closet.
Sounds like a lot of work.
It is a lot of work.
A lot of work for the shoes.
And it drives my wife crazy because they're all over the place.
Is she into it? Does she have her own collection?
Well, because she's married to me. So
she has to be.
She has her own collection.
Okay.
Yeah.
All right.
And I think I did, and I'm being very honest, and I'm looking into the camera for this. I'm being very honest when I say this. And the world needs to understand this.
I'm excited.
I have purchased my last pair of sneakers.
What?
No. I don't have any more space.
It's in you. Like you're gonna see a pair and you're gonna be like, I said it, but
probably me and my boy Marcus, who you guys will meet one day. We'll have him on the pod, and you'll meet him obviously.
Yeah.
We always exchange sneaker questions, like should I get these? What should I get? Blah blah blah, like every single day. And
every single day sneaker talk.
No, I'm serious. And he's like, you're not done. And I'm totally done. This last pair, this guy in Australia is making them.
Okay.
For me, and
let's see how you do.
Yeah.
Well, thank you for mine, and I'm very happy to wear them today.
Listen, I'm happy that you wore them on the asthma episode.
100%.
Since I am so passionate about asthma.
I can't wait to hear you talk about asthma. You know I have asthma.
I didn't know that until the other day.
Yeah. So we're going to talk about it. This is an important topic for me on a personal level.
I think, now listen, like you're in your 30s, we won't say, right? You're in your 30s.
You can say late 30s.
Okay, I can say late 30s?
Yeah.
You think that's late 30s?
It is 100% late 30s.
Okay, fine. We'll say late 30s. And you've had asthma your whole life?
I did, but it was on and off. Do you want to jump into it or you want to save it?
No, I'm just going to ask you one question.
Okay.
All right? And I don't feel bad about this question. I just want to hear how you answer it.
Yeah.
What's asthma?
Oh, I don't love that coming from you. I first got diagnosed with sports-induced asthma.
How old?
I was 14. I was in high school running track. That's when it really started to get bad.
Okay.
So it was only like no other signs or symptoms. It was only when I was doing exercise.
Yeah.
Strenuous exercise.
Yeah.
Looking back, I think that there were probably signs earlier that my parents just didn't hone in on.
Like what?
If I got a viral infection, I'd get short of breath.
Okay.
There were definite periods in my time when there was a lot of wheezing going on, but I just managed it. I didn't think too much about it. And my parents didn't either, quite frankly, like not in a bad way. I just think they were like, her breathing's a little off. She might be sick. And then that was that.
When you say you managed it, what do you mean by that?
You know, this is going to be my downfall because I really never have managed my asthma the way that I should have. And I will admit that.
Yeah.
So I, at a young age, just felt like if I was doing deep breathing exercises, staying calm, because the asthma attacks make you want to just go into a full anxiety space, right? But I was like, I can breathe through this. And I would sit through it and I would come out the other end. I'd feel fine. I'm like, I've conquered the world.
Yeah.
And I would continue on with my day. And I was like, I've treated my asthma. Like that was my thought process. But I was little, right? I'm talking when I'm like 10, 12 years old. Yeah. Well, fast forward and I'm running track and I was quite good at it. And don't you look at me. I was so fast.
So the other day we're like having this discussion and we're talking and I have no doubt that you were fast or whatever. It doesn't matter. Like I have no doubt. But she was like, I was a track star in high school. Track star. I ran the 2, the 4, and the 8, right?
Yeah, and the 4x4.
And the 4x4.
I was anchor. If people, they're going to know.
I don't even know what anchor means. I didn't run track. But you were the anchor. Okay. All right.
So anyways, my mom would have to be with my inhaler at the finish line when I came in first place all the time. But I couldn't breathe. Like I couldn't breathe.
Yeah.
But I knew too, I would take a couple hits off of albuterol.
Yeah.
Walk it out. Yeah. And I recovered fairly quickly. The episodes got worse over the next couple of years.
Yeah.
But still, I was only using albuterol and I was only getting that prescribed through a nurse practitioner, through a primary care doctor. So I wasn't getting like a workup, let's say.
Did that experience motivate you to become a nurse practitioner, by the way? I mean, because you're a nurse practitioner now.
Yeah.
Right.
Yeah. There's been nurse practitioners in my younger years, because the dynamic was different where I did look and think, I want to be a nurse practitioner, but I'm going to treat patients in a different way.
Yeah.
So yeah, I think it did touch on it. But anyway, so after my high school years, I was always very, very active. Most of the time I could carry out an exercise and be just fine.
Right.
Maybe I'd feel it coming on. I would take a break. It wouldn't turn into a full asthma attack. I started mountain biking and trail running all the time, like every week. I was trying to find a new place. And my worst attacks, one of them was when I was mountain biking back in Tahoe. Of course, in a place where I had no cell service. I didn't have my inhaler. I was so bad. I never carried it. I knew I should be. I'd be like, oh, I forgot to put it in my bag. Awful. So I had a really, really bad attack to the point where there was no level of meditation or calm or breathing that was going to fix this. And as the minutes were going by, 10, 20, 30, I could not breathe.
Who were you with?
I was with one friend who was not medical, who had no idea what to do.
Right.
Like, if anything, I was trying to calm that person down, quite frankly. And it was the first attack that I had that I truly thought, and it sounds crazy, but I truly thought, am I going to come out of this? Like, I can't breathe. Like, how long am I going to feel like I can't pass air?
Yeah.
So I got through that. We got off the mountain. I didn't have to call anybody, couldn't call anybody, didn't have cell service. But it was extremely traumatizing. And after that, I was like, okay, I don't leave home without my inhaler now. I'm still, and we can talk about this, why that recovery, it didn't get worse. It did for quite a period of time, and then it got better, and thank God for it. Fast forward, I did a lot of exercising, tend to not have too many attacks, and then I was doing a trail run in Malibu same sort of situation. I loved hiking, so I'm always finding myself out in the middle of nowhere, and could have swore that my inhaler was in my bag and it wasn't. So exact same scenario happened again. And after that, I was like, okay, I have to start taking this seriously. I have to get this properly diagnosed. I need to know the real treatment plan. That's my next step.
Yeah.
So went to the doctor and ended up getting on albuterol rescue inhaler and Spiriva, correct? Was that what was the
one of them.
jam at the time?
Sure.
I think so. Symbicort. It was Symbicort. So I was utilizing them. They seemed to be helping, and then they were helping. So I stopped using them. Yes.
Yeah.
So I stopped using them.
Yeah.
And I did quite well for several years. Most recently, we talked about this. COVID came. I got COVID, had no symptoms. Was like, this was the easiest thing ever. Wasn't a huge believer in long COVID. This is early on. And shortly after COVID, the first viral infection I got, I started to have asthma symptoms in my day-to-day. I'd go to clinic. You could just hear me wheezing. All my staff would become like, listen to my lungs, everybody, because you could just hear it. I was like, let's educate everybody. Everybody was listening to it. And I still, obviously, I kind of laughed about it. I wasn't taking it seriously, but I could see that symptoms were getting worse and worse, to the point where there were several nights where I couldn't breathe all night. And my ex-husband at the time, he was a hospitalist. You would have to drag me to the ER where I work with all the people that I work with. You know, I just didn't want to have to go. And he's like, you have to go to the ER. So I go to the ER, and I was pretty bad at that point. And I was so scared. And they gave me a ton of steroids and then more steroids, and then sent me home on 80 milligrams of steroids for like 3 weeks. And that started my annual ER visit for the last 4 or 5 years, which is not ideal.
Your story is not uncommon. Like, her story, everybody, is a classic younger female mom, you know, into health, into a classic story, because nobody really wants to have asthma or wants to think about it.
Yes.
One of the reasons that I got into education was really because I noticed that patients didn't quite understand what they had. And if they didn't understand what they had, they were less compliant with their therapy and didn't really think about their therapy because they really had no clue what was going on.
Right.
And so, again, when you look at asthma, and now we're going to talk about what asthma actually is, okay? One of the words she said was restrictive. Now, when you think about the lung is a bunch of pipes that lead to a bunch of balloons all stacked on top of one another, okay? And these pipes are surrounded by muscle, and the balloons is where gas exchange takes place, right? So if you zoom in on one of the balloons, you can see the blood vessel going around the balloon. The red blood cells go around the balloon, right? And then oxygen unloads and gets onto the blood cell, goes to the rest of the body, whatever. But asthma is allergic inflammation of the pipes carrying air to the lung. So every single breath you take, you're snatching your environment. There are so many different molecules in that environment. And then those molecules can have an impact on the cells that make up your pipes, right? Your bronchioles,
Right.
all right? So you have inflammation there. Now, another word that Savannah said earlier is she said restrictive. So when we think about lung disease, okay, lung disease can either be what's called obstructive, which is the inability to breathe air out, or it can be called restrictive, which is your lung feels small and you can't take a big breath in. Now, asthma patients feel restricted. In other words, they feel like they can't take a breath in. It's because their lung is full of air. But by definition, asthma is obstructive. So you cannot breathe air out. That is what asthma is. And the way that we calculate that is we look at a number. It's called your forced expiratory volume in 1 second, right? You blow air out. It's the amount of air that you blow out in that first second after you take a big breath of air in. When you blow that air out slowly, that's obstruction. That's what obstruction is. That's what you have, right? The inflammation of those pipes is secondary to something in the air.
Right,
it can
right.
be dust mates, it can be tree antigen, it can be pollen, it can be grass antigen. all of these molecules cause this inflammation in that pipe. Here's the thing that most asthmatics don't think about, probably including yourself, is you are not changing your environment. Your environment is the same. Like, you've lived in Ventura or Carpinteria, whatever, your entire life. What you're surrounded by is what's aggravating your airway.
Right.
You always have a certain level of inflammation in that airway. It's always there. Occasionally, you might breathe in a bigger volume of whatever it is that you're allergic to or is causing that inflammation, and then boom, your symptoms change and you get acute inflammation of your pipes. You're wheezing, you're coughing, like those times you were mountain biking or that time you were hiking up the mountain. You're wheezing, you're coughing, you're short of breath, and you're like, holy shit, I can't breathe. What do I do about this?
Right.
And so that's why we treat asthma. Now, the way that we treat asthma has evolved over the course of time with the advancement of therapies, right? What I want to explain, because I think it's important for the audience to understand, is how this inflammatory process takes place. And so you have this layer of cells in your lung called the airway epithelial cells. I know I'm going to get geeky.
I love it. You're taking me right back to the days.
You have these airway epithelial cells, and when they're exposed to things that you're allergic to, they activate. And when they become activated, they secrete molecules that we call cytokines. These cytokines are going to bind to other cells. When they bind to other cells, these cells get activated and they start secreting more cytokines, okay? Those cytokines that get produced are going to lead to the physical manifestations of illness. So what do I mean by that? So what I mean is there's a molecule called interleukin-4. It's just a name of a molecule. It's like Savannah or Kristen or Drew, right? It's just a name of a molecule. What that molecule leads to is production of a certain antibody in your bloodstream that binds to other cells that release more inflammatory molecules that call white blood cells to the airway. So they call white blood cells to that bronchiole. That bronchiole does not like that shit at all. That bronchiole is irritated by that.
No, thank you.
Yeah, so what's going to do? It's going to contract. And when it contracts, it narrows.
Yeah.
When it narrows, you wheeze.
Yeah.
And you have this attack. You have an asthma attack, okay? Another molecule that's produced is called interleukin-5. It activates a cell called the eosinophil. I bring it up for a reason because we're going to talk about that.
Right.
This cell is really responsible for allergy in the Western world. So whenever you see the eosinophil around, people have an allergy. So like if you see somebody with a rash on their hand or on their skin, the eosinophil probably is around because it's usually eczema or atopic dermatitis, which is also associated with the asthma. Another molecule that's produced is called interleukin-13. This molecule is important because it stimulates the cell in your lung called the goblet cell. You know what the goblet cell does? It makes mucus. So when interleukin-13 is around, you make a lot more mucus, and then you also change the environment of your airway. So you already have the inflammation present. Then your airway starts recruiting over cells that lay down scar and lay down collagen. We call this airway remodeling. But what people have to understand is in asthma, what I just explained is happening
all the time.
All the time. Yeah. Right? So you have this constant inflammation that's always there. Right? So even though as clinicians, and this is where clinicians make a lot of, we make our mistakes, right? Is we take these quick snapshots of people. Like you might come into the office today and you're not wheezing, you feel fine. We're like, oh, she's fine. She's great, right?
Yeah.
But we don't often think about the immune system is constantly evolving because you're constantly taking in a deep breath. So that means that those molecules are constantly activating an inflammatory response. And depending on the bolus that you see, or just depending on your body's mood that day.
Well, that would happen to me. I would go to the doctor often and they'd be like, you're young, you're healthy. They'd listen to my lungs sound fine. They're like, isolated event, move on. You know, use your albuterol when you need it. And I was like, okay, you know. I
don't like taking advantage of young people because we do that a lot in medicine is because young people are so plastic and they're so resilient and they kind of bounce right back.
Right.
We just give them more leeway. When if you were 70, we'd be like, oh man, wait, we better do something about this.
We got to do all the tests.
We got to
and
do
make
all
sure,
the tests and all the things, right? But with an asthma patient, a lot of times they're not given the right therapy. They don't understand what they have.
Sure.
They don't know what to do, and they run into all these scenarios. So that's one of the reasons why I went into this.
So, Jamie, I know you have a lot of stories about asthma patients, specifically ones that are younger.
Yeah.
Can you share some of those with us?
You know, it's interesting. As you were telling your story about being a track athlete, superstar. In
Pretty
high
much.
school. Yeah, running the 2-4 and the 8 and the 4x4.
Yeah,
As
just
an anchor.
really good. Really good. Won a lot.
There was, you know, probably my second year in practice. There was a parent, right? 2 parents who had this younger daughter. And I know she doesn't mind I tell her story. But they had a younger daughter. She was 16 at the time.
Okay.
And I remember the dad came up to me and said, Dr. Rutland, listen, I've been to UCLA. I've been to USC. I've been all over the place to try to fix my daughter's asthma because, listen, she's going to the Olympics. Doc, I swear, she's going to the Olympics.
Oh.
She can run. She's going to go. She's going to go. But she's got this asthma. She's got this thing, and they've tried all kinds of inhalers. And typically speaking with asthma, you use an inhaler first, and then you increase the dose of the inhaled corticosteroid of the inhaler and blah, blah, blah. And at the time, asthma had evolved in terms of management. So asthma had gone from this disease that you manage locally to truly understanding what the inflammatory parameters meant systemically. And so what we did was we started to manage patients with systemic products, with injections that we would give patients and give themselves a subcutaneous injection every month or every couple of weeks. And I was a younger guy, and I was just getting into educating and teaching and understanding immunology and all of that. And I was a big proponent of managing asthma systemically. And he had kind of done his research and looked online and found me. And in the office visit, you know, I'm looking at her, and I told the parents to leave the room, and I just asked her straight up, and I was like, listen, like, what is your dad are you really trying to go is this going to happen? She's like, yeah. And I'm like, okay, fine.
All right, let's take care of this.
And she was nationally ranked, like she was a track star.
Yeah.
Like not that you weren't. She was a track star too.
Jamie, careful.
Anyway.
I didn't go to the Olympics.
So, right. And honestly, and so I put her on a medication that inhibited one of the inflammatory mediators that led to the recruitment of cells into the lung and led to asthma exacerbations. Right?
Are we still using this drug now?
She's still on it.
Okay.
So you use these inhalers first. So you have to be on inhaler therapy.
Right.
And then if somebody's on inhaler therapy, and then they demonstrate what's called type 2 inflammation, which I think I've talked about on this podcast before, then you can additionally put a patient on this medicine. So I did. So I put her on the medicine. And the molecule is called dupilumab. It's an interleukin-4 inhibitor. It inhibits a cytokine that leads to inflammation in the lung and increases asthma exacerbations and cell permeability and all that. Sorry to get geeky for a second. But I put her on it, and it changed her life.
Oh, gosh.
No more asthma attacks.
Wow.
She could breathe. She could take a deep breath. She could run.
Yeah.
She won like state. She ended up getting a scholarship to Oregon. She went to Oregon.
Where all the trees are.
Right. And, you know, her asthma started acting up again.
Of course.
So she ended up transferring to UCLA.
Oh, it got that bad?
Yeah. Like they had to transfer. So she transferred back down here. She's still on all the therapies. She's on all the inhalers.
Okay.
She's on, you know, dupilumab inhibiting interleukin-4. And she made the Olympic team.
Oh, get out.
Yeah.
She did it.
She did it.
That's great.
It's crazy, right?
And have you touched base with her recently?
I was literally just on the phone with her 2 seconds ago.
And she's still on all of her treatments.
She's still on all the treatments.
I like a success story like that.
Yeah. It was one of my first success stories in severe asthma because we were just instituting the newer products to inhibit, you know, the cellular communicating molecules, which of course is like my jam. I like to talk about that kind of stuff. So it was super interesting. And the fact that the first person I put on it ends up going to the Olympics, 8 years later.
Yeah.
Or 6 years later, whatever it was, is pretty special.
Oh, it is, most definitely.
Right.
So the management that she is currently on,
Yeah.
same management we're using now, how much has changed?
So she's on an inhaled corticosteroid.
Okay.
Right? Inhaled corticosteroids, what they are is they're molecules that will penetrate the cell membrane. They will get into the nucleus, and they're going to calm down the production of inflammatory mediators, right? They're going to calm down the production of molecules that lead to inflammation, okay? They increase the production of molecules that reduce inflammation too.
Right.
So that's what they do. Then there's a long-acting beta agonist. Long-acting beta agonists keep that muscle from contracting. So they keep the muscle dilated. So the smooth muscle stays dilated. And when that muscle stays dilated, it means you can breathe air out faster, right? And then she's also on another agent called a long-acting muscarinic antagonist.
Right.
These agents also dilate your muscle, but there's also a receptor for them on a white blood cell. So when that muscarinic antagonist binds to that receptor on a white blood cell, it basically tells the white blood cell to shut the fuck up. It's like, relax, like calm down.
Yeah.
Like, I need you to just calm down, right? So it does those things, and the person is on the molecule that's an injection every couple of weeks.
Once a patient starts these medications, how quickly are they going to see relief?
Great question. So we call the injections, right, that inhibit specific cell mediators, we call those biologics. I call them cellular communication inhibitors. And since this is the health exchange, we'll just call it that, like cellular communication inhibitors. So they tell cell communication to like stop, right? So you don't get inflammation. Dupilumab, which is the one that we're using in this patient,
Okay.
can show reversibility of airway disease within a couple of weeks. So you can see the patient get their ability to breathe air out better. 70% improvement within 2 weeks, which is crazy, right? And so that this has had a significant impact on the patient, and it helps because once I give a patient this, they're going to tell me, they're going to be like, oh,
I feel so much better.
I feel better.
So unlike me, when the symptoms went away and I stopped taking these, you need to continue even if you feel like you're doing well.
Yeah. So again, one of the misconceptions with asthma, right, is that it's this disease that just like, oh, I have symptoms now and it's just right now. And then once you don't have symptoms anymore, then you're like better, you don't need your medicine. Like, that's not the case, right? Because it's all inflammatory. So when you're treating somebody with asthma, the steps you take to manage it, the first step, and this is how we have managed asthma now for years, we call it the GINA strategy, the GINA guidelines, Global Initiative for Asthma. It's how we manage it globally. The first step includes an inhaled steroid with a short-acting beta agonist. So you're going to use albuterol plus an inhaled steroid, right? So like the old management, which is kind of what you're on, right?
That sounds like what I was on.
Yeah. The old management was use albuterol for step one.
Right.
You were still exacerbating, so you weren't a step one really patient anymore. She needed to be on maintenance therapy. So the first thing is use albuterol and an inhaled corticosteroid. And there's a product for that. It's called Airsuppra. It's a brand name. It's got inhaled corticosteroid and a short-acting beta agonist.
This one's newer, right?
It's newer.
Yeah. Okay. I've been hearing about this.
Yeah. It was approved within the last year or so.
Okay.
So that's what you do first. Then if the patient still has symptoms, you add maintenance therapy, which is a long-acting beta agonist plus an inhaled corticosteroid and a long-acting muscarinic antagonist.
Okay.
Right? That medicine's called Spiriva is the LAMA. The inhaled corticosteroid and the long-acting beta agonist, there's a bunch. There's Advair, there's Symbicort, there's Brio. There's a bunch.
I feel like these are the names that people are familiar with.
Right. Those are the names.
Jamie, you explain this stuff so well, but I want to bring it down so that the listeners can completely walk away and have a clear understanding of what you're referring to. Pull it in for me. Explain it in a way that everyone's going to understand.
All right. So remember earlier when I said asthma was allergic inflammation of the pipes carrying air to the lung?
Right.
Right?
Yes.
So inflammation is basically a bunch of white blood cells together, right?
Yeah.
So asthma is like having a party. So say Hillary is having a party and Hillary wants a bunch of people at her house. Okay.
I like where this is going already.
So Hillary is making phone calls and she's calling Savannah. She's calling Kristen. She's calling Drew. She's calling Megan.
Love
right?
it.
And this house is just filling up with people, right? And then Peter's coming and Paul's coming, right? And crazy Erica's coming, right? And here comes Hooper, right? And then here comes Alex. So now you've got this room full of all these people. That's like your airway. So now your airway is full of all these white blood cells, right?
Yeah.
And so it's getting really loud and the music is bumping and the walls start beating really hard. That's your smooth muscle narrowing, right?
Yeah.
Because it's a big party going on and that smooth muscle's narrowing and your airway is getting congested, right? Then people start spilling their beer, right? That's mucus getting produced, right? So basically what's happening with asthma is you're just having this huge
Crazy ass party
in your airway, right? All the time, right? And so
it's not sustainable.
Occasionally, right? Occasionally the crazy friend shows up,
Yeah.
right? And the crazy friend is,
We'll call her Savannah.
It's perfect analogy, right? Savannah's like really loud, really energetic, turns up the music, like brings another speaker, right? That's like when you were going mountain biking that time.
Yes.
And you were just breathing in all that stuff.
Yeah.
And your airway just got really loud. Your airway was like, dude, I do not like what I just breathed in.
Right.
All these cells rush in. All these people rush into that party.
Yeah.
And you're feeling it.
Yeah.
Right? The next door neighbor's feeling it, right? And when you're having that party. That's what asthma is. It's just a party in your airway that's really unwanted. You don't want to have that many people in there.
Yeah.
You don't need that many people in there all the time. It's your body overreacting to these things. So when you're managing it with inhalers and even with those injections,
Right.
you're just telling people to leave.
Get out.
Hillary, get the fuck out of here. Like,
It's
you
2
gotta
a.m.
go. It's 2
a.m. It's time for bed.
Right. It's exactly. It's time to go to sleep. Right. That's what you're doing. But you have to constantly do that.
Yes.
You have to constantly manage it. Right. Because if you don't constantly manage the party, it gets out of hand and it gets too crazy. So basically, the inhalers
Right.
and the biologics
Yes.
are like the bouncers. Like, you got to go.
You got to get out of here.
You got to get out of here. And so most patients think, right, that, all right, the bouncers made some people leave. Some people have left and everything's all cool, right?
Yeah. This is me.
Right? It's you.
This is me.
But really, Savannah just went to go take a piss. She's still in the bathroom. And so this thing
She's
can get
coming back
loud. Right. She's
for round
coming
2.
back. She's coming
Girl
back.
wants
Right.
more.
Right. Savannah's not going anywhere. Right. And so you have to understand.
Everyone's going to be like, I want to hang out with Savannah.
Right. Exactly. So you have to understand that because Savannah is always a threat, you got to calm Savannah down every single day. You got to maintain Savannah. So whoever that person is, whether it's your, Air Supra, or whether it's your Symbicort, which is your maintenance therapy. Air Supra is your rescue therapy. You're just going to use it every once in a while, and you're just going to tell Savannah, listen, you can calm down a little bit, right? That's for somebody that has a Savannah, and only Savannah is there.
Yeah.
But sometimes people have Savannah and Hillary and Bobby, right? Because they all live in the same place.
Yeah.
Right? And so if you have all of them, you need a little bit more. So you not only do you need the Air Supra, but you're also going to need the Symbicort or the Brio, or, you might even need 3 things to calm it down. We call that trilogy, to calm down that inflammation,
Right.
and to calm down that activation of those cells that lead to that loud party that you don't want. Does that make sense?
It does. It makes perfect sense. I need to get back on my medications, is what you're telling me.
I mean, this is the thing for you because you got young kids.
Yeah.
Right?
Yeah.
And you like to hike.
I'm very active. I mean, I told you this most recently. Now I'm a single mom with my 2 boys, and they're 5 and 3. And before, it was just when I was really active, but now it hits me. Essentially, I get a little viral bug, and then I'm laying in my bed at night and I can't breathe. And so the thought of that happening with just myself and my boys is
scary.
It's terrifying.
Yeah.
It's terrifying.
And that's the thing about having little boys and even little girls, right? Is these children get viruses all the time. We talked about that, right?
Yes.
These viruses also activate the party. So when the viruses come in, they're like, hey, what's going on, everybody? Like, let's get everybody back. Where's Savannah at?
Yeah.
Right? Where's the speaker? And they come in there and they bind to those cells and they increase that party. They increase that music and your airways get loud. So when you get ill, when you get sick, or if your child is sick, that's when you got to be like, where is my maintenance inhaler?
Yes.
Where is my rescue inhaler?
That's a really good takeaway, because we are all at home seeing our kids getting really sick. And oftentimes, sometimes our kids we talked about this too, they have a little bit of a runny nose. Yeah. It's not that big of a deal. And then it gets to the parents.
Right.
And we're like down and out.
Right.
Or in my situation, I'm having this massive asthma attack.
Right.
For my little ones,
Yeah.
Viral, in fact. Yeah. So, okay. Be ahead of the game.
Be ahead of the game. So, and I can give you an example of when I wasn't ahead of the game. My 12-year-old and 9-year-old play soccer. They're soccer players, right?
Yeah.
They're athletic and they're good. But one day we were on the field and my wife and I are watching our 12-year-old play, our older one. Because our younger one, not so much, this doesn't happen to her. But our 12-year-old is playing soccer and she comes to the sideline and she says to me, Dad, I'm like dizzy and I can't breathe. And I'm like, what? And she's like, well, it's been going on for a while and it's a game.
Yeah.
She's like, but I can't breathe. And I'm a pulmonologist. Right? Like, this is what I do for a living. But here's my 12-year-old that's telling me that she has asthma symptoms.
Right.
And I don't have a therapy for her with me.
Yeah.
Right? I mean, I felt like a complete failure. Like, as a dad, I'm like, oh my God, not only
dad mode. And,
not only am I failing as a dad, but I'm failing as a pulmonologist. I don't even have the appropriate things to take care of her. But, at that period of time, I put her on the medication that's required for a 12-year-old with asthma. And now she's fine. Like, she's feeling great. And that's that. But these things are common. These things happen. And we have to be able to take care of these things. And we have to understand these things, because when I'm explaining to her what asthma is, I explain it to her just like I explained to you guys, talking about the party in the airway, because she has to take medicine every day. And she's got to remember that. And she'll say, Dad, party's a little loud. I need my inhaler, right? And I'll give it to her, right? And then we'll calm it down. But these are things that I need to know. I got to know as a parent. And obviously I know them as a physician, but
Sure.
Yeah.
How much asthma are we seeing in children?
It's interesting. I was trained as a adult pulmonologist. Right. And I did medical school for 4 years, internal medicine residency for 3 years, pulmonary and critical care fellowship for 3 years. Okay. And I was trained as an adult pulmonologist. But when I started practice, I started getting a lot of second opinion consults from parents and their kids that had asthma.
Sure.
Because I'm not criticizing pediatricians or any other physicians. I'm not. But these kids would have symptoms, but they weren't being treated appropriately. Like, they just were. I'm not going to say they were ignored.
Were they hesitant, or you think because they're kid? What was the?
I think they were more hesitant because everybody gets scared to give kids medications and things like that for some reason. But asthma is something that needs to be treated aggressively. Otherwise, the kid has awful disease, and they have an awful childhood and they can't do anything.
Right.
They can't go out to recess and spend some time with their friends. And so, because I saw asthma a lot as a second opinion, that's why I started seeing peds, was because it was undermanaged in the area where I live.
Right.
And so I felt like I needed to manage it. And that's when I started lecturing on it more often and started teaching about it more often, was because it wasn't managed as well as it should have been in the area of the country that I'm in. And so pediatric asthma is a common thing.
Yeah.
Right? It is very common. You're going to see it.
Yeah.
When a pediatrician or an urgent care doc says to a child, like, say the child is 3 or 5 years old, and they utter the words bronchitis and they say that to the parent, like, that should trigger that, like, hey doc, are you sure this isn't asthma? Right? my kid tends to get this every 3 months or every time they're infected with a virus or every time they get sick.
Right.
Like if they're getting this kind of inflammation, this kind of mucus production every time they get sick.
Yeah. Could this be?
Is this a chronic inflammatory illness, right? I mean, it's common enough that the answer is probably yeah.
So we also hear this term of child asthma is something you can grow out of.
Yeah. Yeah.
I know there's some anatomy that's involved in that, and there's talk to us about it.
So again, the immune system is developing as a child ages.
Right.
Okay. So your immune system gets exposed to something. It's like, okay, cool. I'm going to have some inflammation. I'm going to create a party over here. But the next time I might see this thing, maybe I don't need to make the party as big. So the inflammation kind of goes down, right? Over the course of time. So people took this as like, well, there's a certain amount of kids. I think the number was like 50% of kids would grow out of their asthma, which I don't think it's a real thing. And the reason I say that is because there are so many adults that come to me at like 18, 19, 20 years old with asthma. And they said, oh, well, I had asthma as a kid. And I'm like, no. You've had asthma this whole time. You just haven't treated it, right? And so I don't like to say to parents, your kid will grow out of their asthma.
Right.
I say, listen, your child has asthma and we're going to treat it. Well, how long are we going to treat it, doc? We're going to treat it as long as
we need to.
As long as they respond to the medication.
Yeah.
That's what we're going to do. If you want to trial a time period off of medication, we can do that, but we have to be cognizant of the season. We have to be cognizant of the environment, right? There are areas in this country where asthma is more prevalent because of the environment.
Of course.
Like diesel trucks are driving through Compton. They're not driving through Beverly Hills, right? And so that air is a little bit more dirty, and those kids have a lot more asthma. And it's a problem because they have a lot more asthma, but they don't have a whole lot more access, which is an issue. And again, this is one of the reasons why I'm so passionate about managing asthma is because, you have to be able to get to a certain area of the country, get to a certain neighborhood, and teach the physicians in that area how to manage a disease state that's prevalent in their area. I'll tell you a Disneyland story. And this is an asthma story, okay?
Okay, give it to me.
So I'm at Disneyland.
Okay.
This is like maybe 4 years ago. And I'm with my kids, and at the time my kids are like 8 and 5 or something. And we're in line to get on Astro World, right? Which is like right in front of Star Wars and right in front of like the Dumbo ride at Disneyland.
I love that you know this.
I love Disneyland. I'm going on Saturday. Oh yeah, I love it. So we are sitting there in line, and my wife's going to go on the ride with the kids.
Okay.
And I look to my right, and I see a 2.5-year-old in a stroller who is just scratching their arms, just like, and really, really red.
Yeah.
And then there's like mucus like pouring out of the nose, right?
Okay.
And then I see another like 4 or 5-year-old, and I can hear them like kind of audibly wheezing.
Oh, goodness.
And I look at the mom, and I'm like, everything okay? And the mom was like, my kids are really sick. They get like this a lot. They have rash. The doctor says, just put this stuff on the rash topically, and they'll grow out of this, and just to deal with it. And I was like, you poor mom.
You poor mom.
And so I pulled out my phone, and the teacher and me came out.
Yeah.
And I went through the immunology of atopic dermatitis, which is heavily associated with asthma, right? Rash, which is eczema. And I went through all the immunology of asthma, and I asked the mom what products they were on, what things they were on, which was like nothing, which I was like, are you serious?
Oh, goodness.
Right? And I said, listen, I had my card. I was like, come see me, whatever. Anyway, and we took care of the situation. The patients are doing great now. And it's just,
what a blessing.
It's so common.
Yeah.
And it's so obvious to see that we got to do something about it, because 10 people a day are dying from it still.
Yeah.
It's crazy to me.
That's crazy numbers. So there are some myths, kind of like we covered, that relate to asthma.
Yeah.
I think we should go through some of them.
Let's do it.
And you let us know where there's truths.
Okay.
Okay.
All right.
So first myth is my asthma's acting up today. You hear this all the time. I think I say this sometimes. I'm like, today's a bad asthma day.
Right.
Truth?
Truth. So there's truth to this, right? Because again, I get a text message on my phone when the air quality is horrible, and it says like, hey, watch out today for the air quality. Asthma is going to be bad. There could be exacerbations or asthma attacks that you're going to see in the area. Asthma does act up. So I always say to my patients and my colleagues, your asthma management is as stable as your environment. So if you're running, right, if you are going on a jog and you're running and somebody's auto exhaust is right in front of you, that's a big puff.
Yeah.
If you're running under a tree, if you're running in a different garden and you've got pollen around, you're breathing in different antigens all the time. So based upon what's in the air at that particular moment in time, they can activate your inflammatory response and your asthma can be worse and you can exacerbate and you do need to treat that, right? Or you can have worsening symptoms and you do need to treat that. So it's very important for us to understand what our triggers are if we can. It's also important for us to understand that living in Southern California, where we live, and living in New York City, it's two different environments. There's different things in the air in both places. So the only time I ever let my patients change treatment,
right,
if they're doing well, right, is if they move to a different part of the country. They move to a different part of the country, and nowadays you can manage people via virtual health, you know, those kind of things. I'll give them a trial. I'll let them, okay, cool. We can stop your inhaler, see how things go. No problem.
Nice.
Like, right? That's the only time.
Yeah, it totally makes sense.
Other than that, if you live in the same environment,
stay on the same regimen.
You're on the regimen.
Okay, let's do another one. What you eat can treat asthma.
So it's borderline, not even borderline really. It's an autoimmune disease, right? Because it's your immune system over responding to things in the air. That's what asthma is, right? The way I look at this is I always tell all of my autoimmune patients to eat from the produce section in the grocery store because that is what can keep your immune system as efficient as possible, right? It's where all the vitamins and minerals, like we talked about on another episode of the Health Exchange, the nutrition and heart health episode with Dustin, who was fantastic, by the way. So I think it's important for us to understand that the more produce you eat, right, you can calm down the inflammatory response somewhat.
Okay.
But it's not a treatment. It's more of a supplementation to the regimen that we're doing.
Would you do it as more of like a preventative?
Maybe. I mean, I wouldn't say.
Because when are you going to tell the patient, like, go eat the vegetables?
Right. I'm not going to say to the patient, like, hey, your asthma management isn't great. Eat more vegetables. Like,
eat the vegetables.
That it doesn't work.
Yeah.
Right. So I'm going to make sure that the patient has the appropriate therapy, the inhaler or the biologic or whatever. But I will always suggest that the patient eat more things that grow on trees or in the ground.
Yeah, I hear you. Okay, we also have asthma is only a childhood condition. We kind of touched on this one.
Yeah, asthma is not only a childhood condition.
Yeah. People with asthma shouldn't exercise.
Yeah. So
I hear this a lot in clinic.
People with uncontrolled severe asthma shouldn't exercise. Yeah, because we know that there is an element of exercise-induced asthma. People are taking bigger breaths, so they're probably exposing more airways to the molecule that they're allergic to. That's one of the things that can happen. Also, when you have drier airways, it can trigger asthma, and colder airways can also trigger bronchoconstriction. So again, I wouldn't say people with asthma shouldn't exercise. I would say if your asthma is uncontrolled, wheezing, coughing, short of breath.
Not the time to do it.
Not the time to do it, but you need to see somebody and we got to get those symptoms treated appropriately.
I raised my hand. We're going to circle back on that.
Right.
Okay. What about nebulizers are better than inhalers?
Yeah, that's not true. So nebulizers, which are machines that house molecules and deliver molecules that we use to bronchodilate and to reduce inflammation in asthma. So nebulizers are machines that individuals love because they feel like they're doing something.
They feel like they're doing
powerful
something.
Machine they press on to.
Yeah.
But I also think when you look at nebulizer effectiveness versus inhaler effectiveness, it's the same. There's really no difference, right? Inhalers probably are actually a little bit better. Propulsion is probably a little bit better. But again, when you're using an inhaler, you're essentially doing the same thing as a nebulizer. I use nebulizers a lot in people who have trouble inhaling, like in people who are weak, right? If you're weak, so if you have a lot of life experience or you're weak, something like that, neuromuscular condition, you're probably going to use a nebulizer more than you're going to use an inhaler. But 99 times out of 100, I'm using an inhaler.
What about using them side by side?
Yeah. So you can do that. Right? So there are some people that like to
I'm not going to lie. Sometimes when I was like at my peak of, am I going to the ER or not? I'm just throwing everything, you know, my way to see if I could get things under control.
I get it. And I have no problem with that. But I think for you, more importantly, it's evaluating what type of asthma you may have.
Right.
So there is allergic asthma. There's something called eosinophilic asthma. There is type 2 inflammatory asthma, right? And so when we are looking at individuals, right, if you have asthma, what I want people to do, and this is what I want people to take away from this episode, is I want people to be able to understand what type of asthma they have. So they can either ask their clinician, or when you get your blood drawn, you're getting a complete blood count with differential.
Yes.
And you're looking at a certain cell called the eosinophil, and you're looking to see what that number is, right?
That's a great takeaway.
If that number is 150, 200, 300, more likely to have severe asthma, more likely to have an asthma attack and exacerbate. You also might want to measure your IgE level.
Yeah.
IgE is one of 5 types of antibodies that float around in your bloodstream, right? All antibodies are shaped kind of like a Y, right? And so IgE, the feet portion of the antibody, is what binds to the allergic cell, the eosinophil, the allergic cell, the basophil, and the allergic cell, the mast cell. And when that antibody binds to those cells, it releases a whole bunch of inflammation. So that's the problem with it. So you're going to check an IgE level and see if that's elevated, right? And that number is basically any number between 30 and 700 is like elevated.
And a primary care provider can do this, right? You don't
Easy.
have to go to the pulmonologist yet.
Or the allergist. No.
Okay.
Easy. All primary care providers should be capable of drawing a CBC with diff and an IgE.
And kind of guiding whether or not referral to a specialist is even necessary.
Right. And I do think that right now, I would say primary cares need to refer for asthma management, because I think that right now we're not doing an excellent job of making sure that they understand how to manage asthma patients. So I would say right now, anybody that's presenting with a bronchitis or an asthma attack, like they need to see an allergist or a pulmonologist or somebody that understands how to manage asthma step by step. And I think primary care physicians are completely capable. I told you I was going to teach you asthma. I think you're completely capable.
Oh, yeah.
But I just think we have to
I think
do a
there
better
needs to
job
be more
of teaching
education.
100%.
I couldn't agree more.
Yeah.
Yeah. So asthma medications, are they addictive?
No. I mean, the answer is absolutely not. Right. So when you're looking at addictive medicines, what you're looking for is, do people get a release of dopamine when they take it, right? And that's what makes molecules addictive, right? Scientifically speaking, is that dopamine release. I mean, I suppose the brain can be trained that every time you take an Air Supra or a Brio or a Trilogy or a Advair or a Symbicort hit, like you're like, ooh, but like not really. Like they're not addictive.
They're not actually addictive.
No, but you need to take them every day.
Yes, yes. So looking at the future of asthma, where are treatments headed?
Yeah. Treatments for asthma are headed in the right direction because we understand now the inflammatory molecules that are responsible for these exacerbations. We understand why certain cells get called to the party. We understand what activates Savannah and what gets her into the room to bring that speaker. We understand that more and more and more.
Right.
What you're going to see with future therapies is a couple of things. One, for some reason in America, everybody wants the best one thing, right? If you look at cancer therapy, they're using 2, 3, 4 different molecules to manage cancer.
Right.
We're going to be doing the same thing with asthma therapies. They might get 2 or 3 different injections in addition to the inhalers. That's kind of one thing. We're also going to use more cellular communication inhibitors, more biologics. So we're going to hit different types of inflammatory molecules, right? It might not just be targeting interleukin 4 or 5 or 13. We're going to be targeting, we target a molecule called TSLP. We're going to target a molecule called periostin. We're going to target different types of molecules, right? That's another thing. And then the other thing, what you're going to see is the GINA strategy was written years ago before we truly understood the immunology of asthma. So the GINA strategy, as medications become more accepted, as medications become more accessible,
Right.
and there's an argument on if they're accessible or not, you're probably going to see a shift in how we manage patients. Again, the GINA strategy is step 1, 2, 3, 4, 5, 6, right? And you start with inhalers and you work your way up to the biologics.
Mm-hmm.
What we know in the medical literature is the earlier you give a biologic, the better the outcome is, right? And so you'll probably start seeing a shift on giving those biologics earlier, which is probably going to lead to better outcomes in the future when you start and think about it.
Right.
And so my wish is that people come together and start to discuss, all right, guys, like we know this now.
Yeah.
Let's see if we need to, how do we
Yeah.
push it forward? The issue is going to be, though, is cost, right? Because some of these medications are ridiculously
It's always
expensive.
cost.
Always cost. They're ridiculously expensive. When you think about a global initiative, we're talking the entire world. So we just got to make sure that these medications are available. So that's why it's written the way it is.
On that point, is there new medications that are going to be coming out soon? Anything on the market that's going to be a game changer? I know you probably can't dive into it too much and drop names, but
I mean,
I know how it works. But
yes, there's molecules that are going to be game changers, right? And the reason they're going to be game changers is because they're going to be molecules that you can take by mouth that are cellular communication inhibitors. There's going to be molecules that inhibit 2 different cellular communication molecules. There's a molecule that's going to inhibit an inflammatory mediator called thymic stromal lymphopoietin, just a name, and interleukin-13 simultaneously. That's going to have a huge impact on asthma as we move forward. So yes, there's always molecules that are about to be released, but the question always is cost and access and making sure that people have an equal opportunity to be treated. So
we know that asthma can't be cured.
Right.
Do you think that there'll be a day when we can say we can cure asthma?
I think there will be a day where we can say that we cured asthma. But I also think that requires understanding of how an individual molecule activates the inflammatory response of a singular patient. We're getting to that point. It becomes very personalized.
Right.
We're getting to that point. We're not quite there yet. But I think as we understand how individuals respond to certain things, we're going to get there.
That's great. Hopes for the future.
Hopes for the future, for certain. All right, so listen, we're going to end this on a positive note, and we're going to go with another positive pulse. There was a 77-year-old male who presented to my office about 6 years ago. This individual gentleman had had severe asthma almost his entire life since he was 20 years old. He produced a lot of mucus. He was always wheezing. He was always having asthma attacks, and he felt really, really horrible. It wasn't that he looked me up online or was looking for someone like me. He just needed a new pulmonary doctor in the area, and he happened to be in my office that day. I looked at this gentleman's previous labs, and he had an eosinophil count, that allergic cell, that was really high. It was like 764. He had an IgE that was really high. It was 416. This guy was in the ER all the time with asthma attacks. And as I always tell my ER colleagues, if you know the patient's first name and they have a diagnosis of asthma, they don't need to be there. They need to be with me in my clinic. This guy was. So at that particular point in time, he was on all the inhalers that he possibly could be. He was still exacerbating. I put him on a cellular communication inhibitor, a molecule that he had to inject every couple of weeks. This guy came back 2 weeks later, literally 2 weeks after I put him on this molecule. And he was like, "Doc, I have not breathed this good since I was like 20 years old." It was insane. His response, this is a 77-year-old guy. Imagine 50 years of feeling like complete dog shit and not being able to breathe. With one swift push of a button and a click under his skin, this guy was able to get some of his life back. He then rebuilt his bathroom, and he's now renovated his house himself because he could breathe. I don't see anything else that's more positive than that. And it's stories like that that motivate me to continue to educate, continue to teach, and it motivates us to continue to operate the health exchange. And thank you guys so much for listening. We're going to see you guys, or you're going to hear us next Thursday.